I would like to use the standardized CDC slides. And I did also actually I downloaded yesterday, so they updated the statistics. I would say others are pretty much the same, but some statistics are new compared to what I used last year. So you see as a PDF file. Yeah. Wait. In these are learning objectives from the CDC, and those objectives that highly our standardized objectives, something that you need to be concerned about. Of course, I do not want to go for 5 and 6 for the exam. We will do this treatment part workshop. So this is an SD workshop as we will go through the treatment part, but treatment is daring, is tedious. It's not simple. Okay. Again, traditionally, to understand pathology or diseases, we usually refer to cases. It has been a standard policy all over the world in CDC that they will pick up a standardized case to impress upon a clinical scenario. You have a better attention ability. So that's what it is. So I'm going to take you through this, and you can practice it on your own. I would make an assignment last year, but I wouldn't make an assignment because of the assignments to check already. So for those of you who were asking me or asking Mr. Church how to grasp the material, especially microbiology, which has all the kind material, one of the things that I suggested to somebody yesterday as well, that to read the first 2 pages of the text gives you an idea as to what's the best policy to grasp the material. But one of the things is a case study. So we'll begin with a case study. Again, all these ages and names and sex and everything is standardized. So keep in mind there is a sublime message over there. So 17-year-old college student presents to the Student Health Center and seeking advice about contraception. And again, you can see on history taking, these are some of the norms that you go through in order to elicit history from some patients that you want to advise them for. So she is shy about talking about sexual practices. She never had a pelvic exam. And she has had 2 sex partners in the last 6 months, and so on and so forth. But the idea is that why we are asking these things to reach on a diagnosis based upon history. And also keep in mind that why would we ask? I mean, I'm pretty sure that I saw some of you were the clinical training or SOAP notes. Why would you ask last menstrual period? Why would you ask that question in the history? Correct. Just for pregnancy. This is one of the routine questions that we ask for in terms to determine, because that's going to add another angle to it. Okay. And also keep in mind that many a time, that we did take history, clinical examination tests. We're not saying that patients lie, but they kind of tend to be shy about, and they kind of, decline things. So that normally happens, especially in the clinic, especially with this kind of, because she obviously went for another thing, and she was wondering, why are they asking me all these questions? You see the point? So she denies vaginal discharge, dyspareunia. What is dyspareunia? Painful intercourse is called dyspareunia. Painful intercourse is called dyspareunia. This means pain, dysuria. This is a pain. So this is like a sexual history. She doesn't have genital lesions and sores. Now, when they do physical exam, nothing significant. You can also see, this is also important for this particular bacteria that we're going to discuss today, that you may see a person who may have normal genital exam. Okay, so that's another thing to keep in mind. When they look at the cervix through per vaginal examination specula, they do see inflammation there, right? And bleeds easily, and there's a purulent discharge coming up from the cervical os. You know, she denied the discharge, probably discharge was not to fall out. It was there to leak out the head cervix. Look at manual exam, cervical motion, looking for pelvic inflammatory diseases. They pretty much find it normal. Now, these are the questions that should come in your mind, and these are the questions that we'll want you to ask yourself, and then go through the whole lecture and answer those questions. But in this case, since we are limitation of time, we'll try to do that in workshop. We have more time, but this is what normally is the case. You are given a case, you're given a history, you go through the lecture material, and then you answer the question. Since this is a standardized case, so there are standardized answers. So I'll see if I have that ability to post it on ExamSoft so you can practice it. So this is some of the things that you need to practice, but these are the questions that you can ask. What's your initial clinical diagnosis? What is most likely microbiological agent? What lab test you need to do? What is the appropriate treatment at this initial visit? Just hold on. Lab results, when she was sent, remember she said everything is okay, right? When the lab results were sent for positive for chlamydia trachomatis, you see over here, she just came for advice for contraception, right? And it's unknown to her, and she has normal genital exam. There's no sores or ulcer, but she has bleeding cervix. So you can see a bacteria which looks normal, asymptomatic, everything is normal, and then you have a problem over there. So what they normally do, as I said earlier, is that if you suspect, and also keep in mind, this is not a STD clinic we're talking. It's a student health organization, kind of center in the university that she went to seek advice for. Now, they also test for other Neisseria gonorrhea, which was negative. Before 1900s, because we weren't that much developed, there were no antibiotics. And of course, this was not the case that there was no prostitution or there was no kind of, these kind of behavior happening and so on and so forth. So all the risk factors were there. We did not even have knowledge whether this is coming from Syria or chlamydia. Chlamydia was known at the time. We would blame Syria. Also keep in mind, this is later, maybe like 1907 or something like that, when they found out, no, there's a different organism. So keep in mind that our historical treatment of microbiology and aspects are different as we move along. They look for the wet mount of the vaginal smear, right? And there are no trichomonas, but there are numerous white blood cells. Again, that would suggest inflammation there, okay? They look for other tests, as we discussed today. HIV was negative, and of course, pregnancy test was negative as well. Then we ask all these questions that are there. And then again, another challenge for these cases is once you find out that she has an STD and she appears normal, she herself thinks I'm okay, but she's positive for chlamydia. That's a very typical scenario for chlamydia. And that's going to be a problem, because if you think you're okay, right? You're going to pass it on to other people. Other people also think they're okay. So that's where the problems come. That make sense? All right. So of course you can see this is her sexual history, right? And now the problem again will come: how to locate them, how to find them, treat them, and so on and so forth. So there are ethical issues, there are medical issues, there are a lot of things involved when it comes to STIs. And then again, you can see from here, she was sent for a follow-up visit. She again comes positive. So keep in mind that if a person has an STI, you treat it, right? But you don't treat the cause. For example, if she is getting that chlamydia for one of her partners, and she still is having sexual relations with that particular person, so she's gonna get it over and over. There's no point treating her. That makes sense? So that's another issue over here. So you have to either treat them or advise them, and so on and so forth. And then again, you can see she now tells in her follow-up that she has a partner. And then they have to call him up as well, and then test him and treat him, and so on and so forth. So these are some of the complexities that we normally go along and deal with it. But we don't have time and energy and in this class, but I'm just giving like a heads up on that in terms of your thinking and whenever you deal with STI. So we're going to talk about pretty much these lessons today. They tally with whatever we had already decided in terms of the objectives for all microbes, whether it be a bacteria, virus, and so on and so forth. So as I said, that I just uploaded it, and the difference from last year is that some of the statistics are variable. So make sure that you read the current one, because that's what I'm going to ask you. Don't read the last one, okay? Because I do know the PowerPoint that are posted on Moodle are last year. Anyway, so most frequently reported STI in the US, number one on the list. 2.9 million infections in US. And when I was trying to look it up today, just a second ago for WHO, but I said, let me postpone it for the workshop. I don't want to complicate it right now. So let's talk about US statistics today. And again, the annual incidence of other STIs from 2.9 million is human papillomavirus, trachomatis, gonorrhea, herpes simplex, and syphilis. So you can see all these at all times in our population group. Okay, whether it be a person sitting next to you, whether it be a person in the hospital, whether it be a patient, whatever. So that is a reality that we have to deal with. But the way CDC thinks it is going to cost 2.3 for everything that goes along in terms of the that have for STI. So this is their responsibility to come up with not only educate people, but and public health and so forth. So the things that CDC would do is that national surveillance, they want to collect the data, they want people to report it, and then they want to monitor and things where we are improving or the other way around. So these are some of the things that keep in mind. And this 2013 reported cases, so you see, it's pretty much there in each and every state. In some of the states, you can a little bit warmer states have higher incidence than any other state. But again, some of the northeastern have higher indices as well. If you look at the current report from 1993 to 2013, in terms of reported cases on the basis of gender, so you can see women have higher incidences as compared to men, which is pretty high. So that also is important. It has never declined. It's going up and up and up. So it is a big problem here, because it's already it's going up, and then I want you to understand the dynamics of it. Why is it that's going on? It's related to you because, like that girl, they don't know that they are infected. So asymptomatic. If look at by age and sex, they compare men versus women, but most of the time you see this is a sexual activity age for both males and females, but the proportion is way up in women, especially CDC considered this a very vulnerable age from 15 to 24 for both boys and girls, especially girls. And as they age out, so probably their behavior changes, their sexual activity changes, so there's a less incidence of them having these infections. But on a total, so you have 262 versus 33, so about like 3 times more in women. If you look at ethnicity, again, I want you to pay attention to men and women per 1,000 population. And, I know you know more statistics than myself, but you can see here, over here, Asians, for some reason, have very low incidence of men and women as compared to any other. And blacks and probably some of the Hispanic have higher incidence by all standards in terms of infection, in terms of having it in women as compared to any other group. But also keep in mind, there are some other socioeconomic issues as well, health disparities as well, lack of insurance. They're things not simple, not as simple as you think. Okay? If you look at the age that I said to you earlier, among persons in terms of sex, again, more women than men. If you look at in terms of ethnicity, so you can see non-Hispanic have a very high incidence as compared to others. If you look at age, 14 to 25 is more, and if you look at later ages and sex, again, women with that vulnerable age have a high incidence for STF. That's kind of a trend. We teach you in chlamydia, but we trend of others as well. So one of the things CDC want to do is want to have welfare clinics and screen people. So that's the thing. If they don't get infected, and they're going to pass it on to the partner, the one who's screening. So they want to have family planning clinics, screening, have to have youth detention facilities, and so on and so forth. So there's a screening thing they need to do in terms of finding and treating. Right. The other person you always ask for any STIs, or as a matter of any infection, what are the risk factors? Okay, so you can see this because of the sexual thing is an adult disease. People who have new or multiple sex partners, and I will do some statistics from CDC. When CDC thinks multiple sex partner, they're thinking 4 or more. That's their cutoff point. And if they have already one history of STI, they will have another one because that's a behavioral thing. They're involved in that kind of behavior. Oral contraceptive user, why they have a high incidence? Because they tend to think, I've now licensed to do whatever I need to do because I am taking oral contraceptive. So that gives them courage. So that's, like, again, a behavioral thing that people keep in mind, because there was always a threat in the past for people getting pregnant, so to speak, to avoid that kind of risky behavior. But now that, again, is considered as one of the risk factors. Of course, people who lack barrier contraception and have their skins or mucous membranes of different parts of the body in contact with each other, obviously be a risk factor. As far as transmission is concerned, remember, I mean, it's easy for me to ask you, and it's easy for you to say, hey, the best treatment will be abstinence. That's against the human nature for reproduction. You know, just imagine our parents or our grandparents were to do total abstinence, we would not be living over here to begin with. So that's the answer, right? But practically, hypothetically, yes, but you have to have some other things important. And in this case, they are silent, what you call partners. For example, as I said to you, if a male has a risky behavior and he's going to pass it on to a female in the house without her knowing it, and she's going to pass it on to the kids without her knowing it. So the complexity increases in terms of sexual or vertical transmission. This is highly transmissible. Of all the things that we have had, sexual partners will have it. So if one has it, other will have it. It's as simple as that. Okay, and then again, infants, we're going to born to mothers who are birth canal is infected with that, they will get it. Incubation period is 7 to 21 days. That's not good, because this means that you will have longer time. It's not like a person who goes to this promiscuous behavior is going to get it right next second, right? So he's going to wait on that. So that's where multiplication of the bacteria takes place. The other problem is that people can be asymptomatic reservoir. Right, so you keep having it, giving it on to others over and over and over again. Okay, and then finally, as I said, reinfection is common. Doesn't give you once you get. It's no immunity per se. You have it and you got immune for no. If you are involved in that kind of risky behavior, or you're involved in picking up that kind of bacteria from a source, as the source remains, you will have the same problem in terms of reinfection. Pathogenesis, again, that's hardcore microbiology. Obligatory intracellular bacteria, it infects columnar epithelial cells. Columnar epithelial cells, and of course, if you look at your anatomy, one of the places that you have columnar epithelial cell is the female genital tract. When the bacteria divides, that will lead to the death of the cell. Okay, so that's by nature, because diseases are caused by cell death. In terms of their life cycle, they exist in two important life cycle in terms of alimentary body and reticulate body. So these are two important things in terms of chlamydia, and we call EB and RB, and that's what we are looking for when we do the tests. If you look at the life cycle of chlamydia, for example, so you can see from here that it's going to go to cells and kill the cell, multiply the cell, and kill the cell over time. And in this case, for example, it's going to exist in reticulate body, and again is going to change into the alimentary body. And what you need to know, and I'm going to discuss that in a while, is that which one of them is infective. And that is a typical case when we'll discuss parasitology. Very complicated life cycles that these bacteria have. Don't think that chlamydia, when I say chlamydia, I mean only chlamydia as a family, right? So most of the stuff that I've been talking about so far in terms of STI, luckily, is coming from chlamydia trachomatis. But there are Chlamydiaceae family, which is a larger family, and one of the three important species are known to cause human disease. One is a trachomatis, and then again we have pneumonia, as the name suggests, and we have cetacees. So these are three important. Each one of them will cause a different disease. The most commonest cause of blindness in the world is trachoma, right? And this class, what we call a chlamydia, is the causative organism for that. So you can also think important that it's not an STI for STI alone, it's a cause of another significant problem of blindness, right? So you can see a non-gonococcal urethritis, pelvic inflammatory disease, and then conjunctivitis, infant pneumonia, and other problems that we have in terms of causing problems. Okay, now I think this is a very good chart, and I mean, I'm honest about that. I at least got a couple of questions last year to ask you from this particular slide, because basically compiles and compares three important groups that are there who are going to be infected with chlamydia: men, women, and infants. And if you were to make a chart, which CDC has done it for you, you have a local infection causing symptom, you have complications, and you have sequelae that happens after the fact. So you can see from here, if I was to ask you, and again, keep in mind that if I was to ask you, how would men present with chlamydia trachomatis infection? So these are in terms of prevalence, right? Urethritis is the commonest thing. Then proctitis, right, and conjunctivitis. So these are the three important aspects, okay? Now go back to the case study and kind of imagine that when that young girl presented, she basically did not present with urethritis, right? She just came for advice, but they found out, coincident finding, that she has inflammation of the cervix, cervicitis. Okay, so that's common presentation. They can also present through urethritis, proctitis. What is proctitis? Inflammation of prostate in women?
No.
Maybe there is something that I don't know. Prostate in women.
The anal area.
Not anal area. Rectum.
Rectum.
Yeah, rectum. Proctitis. So proctitis is common because of the sexual preferences of people in terms of having vaginal, anal, or oral intercourse in both sexes. So that whichever route of sexual preference they're going to use, the bacteria is going to go and sit over there in both sexes. As far as infants are concerned, most commonly because they're going to be born through the vaginal canal, so their eyes is going to get infected. So they have conjunctivitis. They may also have pneumonia, pharyngitis, and rhinitis. So these are the local symptoms, meaning where the microorganisms are going to enter the mucous membrane or the barrier, or break the barrier. For complication, and also keep in mind, many times people would not present with the local symptom. They may not. So sometimes they present with the complication of the local symptoms. So man may comes with epididymitis. Epididyma is the one that makes semen. So it's there, the sperms. So that's where get inflamed. It's very painful condition in men. And they may also present with reactive arthritis, but that's a rare thing. As far as women, they present with endometritis, salpingitis, which is the inflammation of fallopian tubes, perihepatitis. They may have perihepatitis. They also have reactive arthritis. That's an immune response that you normally get to microbial infection in terms of. Infants may have chronic lung disease. That's the scary part. So the next question you ask yourself, who cares? Right? Who cares? Like people say, I don't care if I have urethritis. I'll keep on doing what I'm doing. So the sequelae for this infection is infertility. The most common cause of infertility for both male and female unable to conceive is chlamydia, especially in females, because if their fallopian tubes get inflamed and they get blocked, so there will no be release of the egg and union of sperm with the egg. But these, for men, is rare. They may have ectopic pregnancy, chronic pelvic pain, chronic arthritis, and of course is rare, if any, in terms of sequelae for the infants. Okay, I'm just going to run through that because I don't want to go each time and tell you what is urethritis, because it's inflammation of urethra, whether it's a male or female, doesn't really matter, but they pass pus, they pass blood, is very painful, very burning, and that's pretty much annoying for the people. And then I'll just allude to some of the problems that may come, because in this case, when I said the number one cause of urethritis is gonococcal infection, but it could be non-gonococcal urethritis. If I ask you what is the cause of non-gonococcal urethritis, you have to answer me chlamydia, trachomatis. Majority of the males are asymptomatic, again a problem. Okay, and then if the sign and symptoms are there, they're gonna pass mucopurulent, mucoid, or clear urethral discharge. The problem with that is the many of men will ignore is as to either a pre-ejaculate or an ejaculate. Okay, so that again would not give them kind of a clue as to what's happening, but they will have dysuria, painful urination. Incubation period, again, as I said, is 7 to 21. Non-gonococcal urethritis, as you can see from here, mucoid discharge in terms of presentation compared to gonococcal, which was like pus. Complication, they have inflammation of epididymis and reactive arthritis, but reactive arthritis is rare. Most of the time, these are the complications, pain that will bring people to the clinic and bring them to the, and this is like a swollen or tender testicles over here that was called epididymitis. And then again, as far as women are concerned, as I said earlier, cervicitis, but the problem is that they are asymptomatic. So if you're asymptomatic, you're not going to do anything about that. Okay, if they do have local signs of infection, pretty much the same for any inflammation. And then again, the problem in both cases for women, as you can see, majority usually are asymptomatic. So why should you go for a treatment if you have nothing to declare? So they are all think that they're in green zone, but it's a high incidence if they are into the risky behavior or if their partners and spouses are passing it on to them. And again, as in the prototype standard case, when they looked at this is normal cervix. This is normal cervix. And, and this is a typical pervaginal speculum examination. Compare that with an abnormal cervix where you see a mucus plug on the opening over here, and you can see inflammation. So that's where that girl was bleeding from. Okay, so that was the blood. But again, keep in mind that one of the very complicated in medicine and very difficult to treat is menstrual disorders, because they would never make out whether it's normal menstruation or it's, it's a disease and so on and so forth, and especially when they go through the spotting. So in this case, they will just present as a spotting and they will just take it as normal menstruation or pre-menstruation or whatever. But when things go out of control, the inflammation is going to become severe. Okay, so you can see over here, because they are asymptomatic, it's right up upper vault of vagina, hidden, not seen, nothing goes through. You just have a bleeding, spotting, and nothing gets noticed. Who's going to go for the test? So things can become to such an extent that you may have necrosis there, and you may have a lot of problems there. To such an extent that infection can go from the cervix over there and go into the main body of uterus, leading to endometritis. And they can go from there to the fallopian tube, causing salpingitis, right? And they can go from there to the ovaries, causing abscesses. And they can even poke a hole into the whole female reproductive tract, right? And call peritonitis in the peritoneum. So you can see, and the whole scenario, we call it pelvic inflammatory disease. And they have these kind of big aches and pain. And then again, many times, as I said earlier, we'll take either premenstrual or postmenstrual kind of pain that they will think is pretty much normal. So it's difficult to diagnose. And then again, perihepatitis, Fils-Host-Curtis syndrome, very common question asked, which is very significant for chlamydia trachomatis complication in women because now liver is involved. Okay. You can see from here, normal fallopian tubes has those cilia things. So when eggs are released, it's going to push eggs towards ampullas for normal fertilization. And again, when infection does occur, you lose the cilia. So what will happen if you lose the cilia in the fallopian tube and the fallopian tubes are unable to push forward the egg release from ovary? So what do you think can hapen? Ectopic pregnancy, correct. So you have a pregnancy in the fallopian tube. So what will happen if you have pregnancy in the fallopian tube? Should I? Okay, it bursts up. Well, if you are diagnosed earlier, we can save you from dying, but it's going to burst up and cause problem. Ectopic pregnancy, of course, is going to lead to death if it's not investigated in time. So you can see from here, chlamydia trachomatis causing pelvic inflammatory disease. So it's like lower abdominal pain, aches and pain, but very complicated. Things are not very simple. The reason being because cervix is there, uterus is there, fallopian tube is there, ovary is there, and all intestine is there. So very complicated issue that we have in terms of young women coming for that. One of the things can happen is acute salpingitis. So you can see acute inflammation of the distal end of the fallopian tubes. Okay, again, I'm not doing surgery class, but it's going to be a differential diagnosis in terms of acute appendicitis versus acute salpingitis. So the presentations pretty much will be the same, depending upon whether it's right. It's going to be, if it's on the right, it's going to be more towards appendix, but it's on the left, of course, salpingitis. And many times a ruptured ovarian cyst presents as a acute appendicitis, and you end up having normal appendix. Okay. So again, what will happen is if you have inflammation, when there's healing taking place, it's going to be healing with adhesion. So this fallopian tube is going to be attached. All of these are inflamed. So there are going to be adhesions. So what is the problem with adhesions? If fallopian tube gets adhered to the lateral side of the uterus, what do you think the problem will be? Well, in pregnancy, uterus has to expand. So if it's something holding the uterus down, it's not going to expand. It's infertility. Or it's going to rupture. So these are some of the problems that women who have had undiagnosed pelvic inflammatory disease may be infertile because of these anatomical dislocations or problems that they go through, right? And again, you can see over here is an ovary, right? And all like we call this salpingo-opharitis because everything's inflamed over there. But in this particular case is salpingitis, which is there in terms of inflammation of distal end of fallopian. Keep in mind that lymphobulominium, we'll discuss that LGB later, but there are many other things which are common in terms of us having these pictures. So don't think that, hey, I just found this is the only cause. There's no only one cause. You have to exclude other causes as well, right? One of the things that we want to exclude was lymphogranuloma venereum. I just told you. Venereum because of the venereal diseases it causes, and it causes inflammation of the lymph nodes over there and have a granulomatous chronic inflammatory response. We already discussed that as pathophysiology. Again, you can see in this case, they are inflamed lymphs over here, inguinal lymph nodes. Again, if these are inflamed, this is the genital area that's drained over here, right? So you have to make sure that even if you don't see something up very obviously, there's something going on which is causing that kind of lymphadenopathies. Okay, the other things that we talked, especially in infants, was inclusion conjunctivitis and pneumonia. We discussed that, especially if they are born through the infected birth canal. Okay, then if it happens in older children, so to speak, like pre-adolescent males and female, they usually have urogenital infections. And again, they are also asymptomatic. They may have history of sexual. I think that's the most important thing, especially if the CDC keeps a data of sexual abuse in kids, because if they are pre-adolescent, there's no other way for them to acquire a organism which is exclusively sexual. So that kind of is a test that they normally do in terms of sexual abuse in pre-adolescent males or females. So if you were to see a case, 8 or 9 years girl or boy having some kind of infection, and they can isolate chlamydia trachomatis, then you really have to go through and find out if there is a history of sexual abuse, because there's no other way for them to get it. All right. How do you diagnose that? Again, the preferred method is nucleic acid amplification test. Just remember that it's called NATS, nucleic acid amplification test. Is a genetic test in terms easy for you to look at the CROR. And then again, cultures usually is not good enough. It takes a while, but some of the tests are not recommended like any other test or serology. What's the point? Because it's not going to cause much of a problem in terms of getting a good, robust immune response. I don't want you to go through that, but I'll just, those of you who are interested, when we say these detective or specific, so we are looking at a very selective genome or plasmid DNA or RNA of that particular. That's what the test is based upon, as we discussed earlier. Okay. All right. I'll skip that. Historically, as I said earlier, there was considered as a gold standard, but I also told you before 1907, we were unable to distinguish between gonorrhea and chlamydia, whether they were the same organism causing the same disease or two different. But we know for sure they're two different now. But this test, especially in terms of rape, sexual abuse, or any other litigations that people go through in terms of legal investigation, approved for use in all anatomical sites. The reason being, as I said earlier, sexual preferences of the people, if they are able to pick up that particular organism from the rectum, vagina, oral, whatever, much will give you a positive test. Again, it's expensive, so you can't do wide screening. Another problem that you do like a screening for general public or high schools and so on and so forth. There are non-application tests not recommended, so don't worry about that. They are there. Serology basically means antigen and antibodies. So you can see that we do that for academic purposes. Typically, the idea is they want to exclude lymphgranuloma venereum from chlamydia trachomatis. You want to look at a CROR and make sure that it's there in the community. That's what we normally do. Okay, the most important thing, and again, as I said, it's not part of me teaching you. I'll just kind of give you an overview, and we'll go a little bit of detail in terms of patient management. But no, I think I've tried my best to impress upon you that it's not simple, right? In terms of patient management, and CDC does have requirement, right? You have to fully. This is like a grids, so you can see from here. Uncomplicated genital chlamydia infection. So they have these regimens which are recommended, but the most important thing that I would want you to know at least is azithromycin, which is given single dose, or doxycycline twice a day. So that's good enough to take care for, and then there are alternative regimens, but this is CDC recommendation. When they want to treat infection in pregnant women, then again, you know, tetracycline is not used. I'm not going to discuss what are the side effects. Let other people take care of it. But we replace that with amoxicillin, but we can give the azithromycin again 1 gram orally in single dose, and then our alternative regimens available for pregnant women. When it comes for neonatal conjunctivitis and pneumonia, again we have azithromycin recommendation, and you can see the treatment is pretty lengthy in terms of days of infection. So I'm just going to skip that. I don't want you to, but I'm just telling you the complexity and again, a referral of a particular infection when it comes to STDs. When there is lymphgranuloma venereum, we call LGV, then you basically go for doxycycline for 21 days. So you can see chronicity of this particular organism for a long-term antibiotic use. Sometimes I say antibiotics, if I say, hey, this is a particular case, and the person has visited STD clinic, and we are giving an antibiotic, which is doxycycline for 21 days. So what do you think will be the cause of that? What is it the physician is suspecting that he put that? So the suspicion for the, or diagnosis of the physician is lymphogranuloma venereum, LGV, in terms of, these are like some of the distractors that usually add to the questions. Again, as I said, reinfection, there are CDC rules and regulations in terms of how to take care of the pregnant women, non-pregnant men and women, and so on and so forth. So these are all recommendations there, and you can read it on. Let me talk a little bit about prevention. Again, that's again a public health thing. And again, we need to screen for chlamydia. But how can we screen if they are asymptomatic? Is that the point? That's like a catch-22 over here. We're going to do something, but it's not there. Okay? So that's the most important problem we have. But what we think is that we can at least, if we do so, we can reduce the incidence of PID by 50%. That's what we think. If we were able to do that, we would rather. But these things sometimes take time for CDC to implement. It can vary from state to state. Then you want to make sure that you get yourself tested for that. I think the most important thing that the CDC recommends, as far as screening is concerned, that all sexually active women less than 25 years should be screened annually. That's what their recommendation is. Okay, whether their insurance covers it or not, whether they think that they need it, what is, again, is up to them. But women over 25 years should be screened if there is a risk factor present. So they probably would imply that since that's the age where all this kind of risky behavior takes place and people get settled, so to speak. So based upon the incidence, based upon the rates, that's what they suggest. But again, repeat testing is required. The reason being because if the causative organism, the source which is giving the infection, persists. Okay. The other problem that we have is, which again is the vertical transmission. So at least CDC can come because you can hide your risky behavior, you can hide all this local income. But the thing is this, definitely most of the time, pregnancy is something that will bring you to attention and seek the care. So they want to make sure that all women are screened in the first prenatal visit, right? And that's very important for them to do so. So that's where most of the time the infections are caught, okay? For men, again, a recommendation is from CDC, sexually active men, young women, if they have the clinical settings, they can go for that. And it's difficult, to kind of propose that. It's difficult to defend that. But again, as I said, that people who, all you need to do is you don't want to be a paranoid. But of course, if you want to go and seek that kind of a risky behavior, so you have your own life in control or at stake, so you want to make your own good choices. Partner management, again, is very important. You want to make sure they're not only tested, but they are faithful. I don't know what that means, though, but they should make sure, say cartoon or joke, say, hey, before you have something, can I look at your chlamydia STI report? So you want to look at, maybe there's an app there, something needs to be done before that contract goes in place. But this is a genuine thing which is there at all time, right? And this, again, is, you can see nothing you can do about that. One of the things you would have thought that, hey, make it mandatory for the marriage license not to be given if they go for STI zones. But the problem then will come that people are going for the marriage before they go for sexual activity. Then they say no. So what's the point? So there is no kind of line that you can draw. The best line will be education, or make your own choices, especially those people of us who are directly involved, who are parents, they have teenage boys and girls. they know. I mean, I'm going to present to you the statistics that CDC has. 60 to 70% people, are there having an activity which is there. And I mean, other than to distribute free condoms, there's nothing they can do. So they think that something needs to be done. But again, the complications are there in terms of partner management. If there is I think the best bet, which not to act like what do you call a sermon, the CDC thinks and hopes that people who are in monogamous relationship tend to do better in terms of not having STIs most of the time. That's what their statistical analysis show. Other than that, they consider this as a risk factor for people in all age group. Okay, now it is a reportable STD in all states. That's something you need to know. Right? But also keep in mind, when I say that, this means this is going to put a scare on people to go and show themselves, hey, you're going to take my name as, that kind of fear, confidential issue. And hey, make sure you don't call my wife, my husband, to let them. But these are all these things that may be there. So there are ethical, moral issues over here. But the worst part, what I'm trying to say, impress upon who would be, the whole system that is going to be corrupted in terms of whatever's happening. We need to counsel the patients for sure. And again, especially if there is asymptomatic and then increased risk of upper reproductive tract, then we have to teach. I mean, it's just like if you go to the website, high schoolers, parents, young girls, all these different categories of people where there's already a very high risk of getting into this situation. So there are some things. It's not like, say, hey, complete abstinence. Well, you can advocate that, but again, that would not be, I would say, physiological in terms of doing that. The best part you can do is that you have to, if they're involved in that high kind of risky behavior, okay? And if the CDC tell you on an average, a high school boy and girls changes 4 partners a year, there's nothing you can do about that, right? Because this is norm according to CDC in terms of percentage of people, regardless of whatever moral or ethical values you have. But what they would do is that they, as a clinician or as a health provider, what they would do is that we try to give them all the stakes involved in this one. And do your best to change the behavior potential that always is there, right? And then again, also CDC recommends total abstinence. I would imply from going to that high risk behavior, whatever that means to you. Monogamous relationship is considered as a good thing, and then limiting your number of sex partners, that again, and then so on and so forth. But again, the whole idea for education is that you need to develop your own kind of level of whatever you think. And I think my job as a professor teaching